If you would like to ask a question during the interactive portion of the webinar, we ask that you use the chat box function listed here on the screen. And you can either make the question for everyone to see, or you can make it be private, and then you would indicate your question in the box listed there. Here is our agenda for today. We'll be first discussing eligibility criteria, member status explanation, when is it appropriate to discharge, how do you plan for discharge, how do you discharge someone from Tennessee HealthLink, notifying the MCO of the discharge. We also have a case study for you, and when is it appropriate to re-enroll. All right, I will now kick the ball over to Jennifer and Kyle.
Hey guys, good morning. We're going to adjust our microphone here, so I apologize if you got any feedback there. We are going to discuss several topics coming up here regarding discharging and various THL aspects that will be either uniform across all three MCOs. If there are any outliers, we will mention that as well. On this first slide here, you'll see the eligibility criteria for members within the THL program. This is outlined by TennCare, so it's across all three MCOs. There's Category 1, 2, and 3. Most of you are aware Category 1 and 2 are based off of claims data, so diagnostic criteria based on diagnosis or billing codes. Category 3 is when you, the THL, determine there is functional need and that you attest to the member. There are multiple member statuses that, was it stati? What's the plural? Statuses, stati, that could be attributed to a member or assigned to a member. There's attributed not enrolled, active enrolled, inactive no BH services, opted out, and discharged. We'll go through each of those now. So the first member status is the most common, attributed not enrolled. These are members who are deemed eligible for services based on either the diagnosis or a mixture of diagnosis and service utilization. These members are not yet engaged or active with their assigned THL, and they remain in this status until some form of data or claims trigger another status. So when a THL claim is paid to an attributed THL, for example, it will change that member status to active enrolled. So something to keep in mind that until we receive that claim, the member status will remain attributed not enrolled. On the next slide, another member status is active enrolled, and just as I just mentioned, these are members who are actively receiving THL services or had received level 2 case management within the 6 months prior to the start of THL. So those members would have reflected as active. These are members that you are actively seeing, and they will remain in that status as long as they're in the THL program until another status changes. Next status is inactive no BH services. These are for members who were active but have not had any behavioral health service claims in 6 months. It's based off of claims data. Timely filing impacts this. So if, for example, a member who is attributed not enrolled would not roll over to this. They have to be active, and then if they don't have any behavioral health service claims within 6 months plus the rollout time period, then their status would change to inactive no BH services. And I like to mention to my THLs that this sometimes can be low-hanging fruit for you to reach out to these specific members and determine if they need behavioral health services. Is there a reason they're no longer in therapy or med management? So these sometimes could be some fragile members that you could definitely reach out to and get them enrolled. Next status, of course, is opted out. These are for members who have declined the service and were either opted out by the MCO or by their THL provider. So this means the member specified that they no longer wanted to be in the THL program. They can notify their MCO or they can notify you and you can opt them out. And the last and most important one of the day is the discharge status. So these are members who've been discharged from the service by the THL provider. And we are going to walk through what that looks like, what that consists of from a clinical and operational standpoint. So I will turn it over to Kyle.
All right, so good morning. So up to this point, it's really been just kind of a review of a lot of information that I'm pretty well aware of, but now then it's time to get into the meat of the presentation and discussing, you know, why is it that we need to discharge a member from this service? And so there's a couple of items listed here that might come into effect, things such as, you know, limited resources. We all know that we have a finite resources as far as the ability to engage members, provide services, and really, you know, being able to address their needs, you know, as far as care coordination, things of that nature. Another reason to discharge is so that we can ensure that we have focused interventions. As long as we are, again, pursuing recovery and pursuing resiliency, that drives a focused intervention. We have far better outcomes. And then the third is, again, this is a service that falls under medical necessity criteria. And so one of the items that we'll discuss further through this is the medical necessity guidelines, level of care guidelines. And so medical necessity is important because it is when the individual has an impairment that's related to behavioral health diagnosis that Tennessee Health Link can assist in addressing or treating. There is a difference. We discussed the eligibility with Category 1, Category 2, Category 3. You know, eligibility is more of when they can receive the service, whereas medical necessity, again, is more of a discussion of when they need the service. Both of those items must be met for the individual to be in the service. So again, you're looking at really two aspects with medical necessity and eligibility. So the next question then is, well, when is it appropriate to discharge? This is going to lead to that, the level of care guidelines, medical necessity criteria, and you'll see on the slide in front of you that, you know, these various domains that are listed here. This is what we use to assess an individual to see if there's need for the service. Things such as medical and psychiatric, mental health, substance abuse, ADLs, vocational, educational, social and family supports, leisure and recreation, legal issues, community resources, financial assistance, housing, transportation. All of those have been identified as domains that Tennessee Health Link can assist in addressing whenever there is a functional impairment due to the behavioral health diagnosis. And so one thing to be mindful of is that completion or meeting someone's baseline might look different for each individual in this service. And so, you know, I know that several of the providers on the call utilize the DLA-20 and others utilize other functional assessments that evaluate severity of need and things of that nature. Different members, their success is going to look a little bit different. Not everyone is going to score a 6 or a 7 in a certain area on the DLA. They may score a 5, but that's still considered within normal limits. It's still considered successful and minimal impairment. So again, that's something to be mindful of, is that just because one individual can or cannot do something does not mean that they've not met their goals and they're not ready to pursue discharge. So to continue that question of when it is appropriate to discharge, you know, some of the questions to ask is the member still benefiting? One of the things that we need to be mindful of, again, this is going back to looking at the limitations of resources, is how much benefit is the member receiving in continuing the service? Are they still making progress toward the goal? The next item is a member participating in the service? Or is this a situation where the provider has begun doing all of the work and the member is merely benefiting but is not actually participating? And in that case, does the treatment plan and the functional need, does it need to be reassessed and really working to activate the member in the service rather than engaging the member in the service? You know, there is a question about when is it appropriate to keep the member on as a client. and things of that nature. So we're going to go into this a little bit greater detail over these next slides. And so this next slide, again, is the member still benefiting? So the way that we look at this, speaking as someone that has been conducting the THL engagement evaluations and coming from the clinical background, we want to be able to identify in the member's chart, in the documentation, is there progress toward the treatment goals? And is that progress related to the Tennessee Health Link interventions? Is it something that they are benefiting from having that care coordinator or outreach specialist or whatever term might be used for that provider? Is there benefit to having that member still receiving that service? And so the next item, again, looking at participation, one of the items that we ask sometimes is, when was the member last seen by the care coordinator? Is it something that you're essentially titrating the service down, and so you see the member once a quarter and maybe you call them once a month, but they're really doing quite well and they're not really active in the service anymore? Are they ready for discharge? Again, the other thing is if the member's just no longer participating and the care coordinator is essentially doing all the work for the member, reevaluating for that need and working with that member through motivational interviewing or some other methodology to move from merely engaging the member to activating the member in their own care. So the next question is, this is a question we get frequently about when is it appropriate to keep a member on when they're not progressing toward their goals. There are some allowances made in the level of care guidelines that the member can continue to receive the service if they're not progressing toward their goals, if they're essentially at a baseline, but whenever THL was attempted to did attempt to discharge, the member deteriorated. The member ended up back in the hospital, had a relapse, had something of that nature. And so, there's some opportunity there. And so one of the important things to do is making sure that that is documented appropriately. And we want to be mindful of those members that are in this population that have been receiving services to maintain their current level of functioning. And without a certain level of service, they are going to deteriorate. They're going to end up back in inpatient units, back in the CSUs, and things of that nature. We want to be mindful of those, but at the same time, we also want to be mindful in regards to recovery and ensuring that we are doing everything possible as clinicians to pursue that with the member and for the member, and not merely just allowing codependency to form or anything of that nature. We really want to continue to strive toward that overall goal of the member being able to function at a high level in the community, utilizing their natural resources. And so that's something to be mindful of. But if that is not a feasible option, and for some of our members it may not be, documenting those attempts, documenting the evidence to support that claim, and making sure it is very clear whenever anyone looks at the record, that member needs that level of support, whether it's history of again, relapse or deterioration back into the hospital, things of that nature. And again, showing evidence that, yes, discharge has been pursued, but has not been successful. And we're going to discuss more about re-enrolling members after they've been discharged toward the end of the agenda today, but again, being mindful of that. So the next item here is one that's a little bit different, so a slightly different approach. And so this is one where a member might be incarcerated or they've moved out of state, or you contact them and say, hey, I'm living in Florida. Or you contact someone and they've passed, the family member picks up the phone and says, they passed away. or maybe you get that information from a primary care doctor or from someone else, and that information is communicated to you. There is allowance there to discharge a member if they meet one of those items. The thing that would be important to remember is to document that information. Who notified you? Was it a family member? If it was, who was the family member that notified you? When did that notification occur? Was it, can you list the phone number that you called to get that information, or list the address that you received that information from via letter? If it's a primary care doctor or something of that nature, documenting that information. Again, you really want to be able to support saying, yes, we discharged this member because we were informed that the member was incarcerated on this day. Just to give you an example of this, just recently at a provider's office, sitting down looking at a member record, we see evidence that the member's been discharged, and there's a note in the record. The care coordinator contacted the member's mother and was told that the member was going to be in jail for the next 7 months. Okay, so they went through and pursued discharge and discharged the member, but then the member ended up showing back up 2 weeks later and walking in for and asking for an appointment. And readily apparent that the member's no longer in jail. He had been, no longer was, and so the care coordinator met with the member, re-enrolled them, got them signed back up, redid the treatment plan, the consent, picked the member back up, and was doing a lot of good work with the member now that he was active and engaged in the service. Now, some of you may be thinking, well, if someone's in jail, don't they lose eligibility for the service? Yes, that is correct. They would eventually fall off the attribution list. The issue is that, again, they have to stay incarcerated for at least 90 days to lose eligibility. And that's also kind of a guideline that we would use surrounding discharge. If a member is going to be incarcerated for 2 weeks, and then you're going to try to re-engage them, we wouldn't necessarily recommend discharge just because of that. We're really looking at, is the member going to be incarcerated for a long time? Is the member going to be out of state for a significant amount of time? If the member is going to be going to Kentucky for a week, you don't need to discharge them necessarily. It's them contacting you and saying, yes, I'm living in Texas. I've lived in Texas for the past 6 months. I'm not planning to come back to Tennessee. It's things of that nature where they're going to be out of state for 90 or more days. They're going to be incarcerated for 90 or more days. And again, all of those, they can be re-enrolled. If they ended up coming back to Tennessee and wanting to receive the service and getting back on TennCare, they can begin receiving the service again, and it's a pretty simple to get them re-enrolled and notifying the MCO. So, that kind of discussed when it is appropriate to discharge. The next item that we want to look at is planning for a discharge. And so one of the things that sometimes is difficult is how do you discharge a member and not feel like you're abandoning them? That's something that I hear frequently from care coordinators. I hear frequently from therapists and other level care providers. And how do you really approach that and ensuring that the member is ready for discharge and they're going to be successful? And so we wanted to touch on this, and again, more information is out there around discharge planning, and of course you have a wealth of knowledge at your fingertips with the various NCOs, whether it's United, AmeriGroup, Blue Care, they're more than ready to answer any questions around this process. But just as a brief overview, we want to look at that. And so one thing to be mindful of is that discharge planning is part of the care plan. And so from the very beginning of the service, you should be having those discussions around when is this service going to end and what is that going to look like, and using that information to not only define the discharge plan, but also to define the treatment goals. So when a member first comes in and they're needing help with, coordinating with their primary care doctor because they have diabetes, that is something that sometimes it's difficult to clearly define a discharge plan around that, but there's a lot of different things that go into that. So the next thing that we're going to be looking at is, what are some of the parts that would be included in that? And so one thing that we're looking at is plans for aftercare, a time frame. All of that is part of the treatment plan, part of the discharge plan. Looking at this, using the example that I mentioned just a moment ago, a member that comes in that's diabetic, their discharge plan should have enough detail that you can evaluate when it's been met. Same way with the treatment plan. When has that member been successful and met that goal? Is it when they've established with a PCP and they've attended at least 3 appointments? Is it when their HbA1c is falling below that poor control number of 9? Is it when their blood sugar is not averaging above 100? And again, please, these are all hypothetical situations. I'm throwing numbers out just as hypotheticals, not as specific examples to use on a treatment plan, but again, using that level of detail assists the discussion whenever it does come time. And once you really get to that point where, as a team, as a clinician, you're looking at, is it time to discharge this member? Have they been successful in this program? And so that leads to the next slide. And how do you discharge someone from THL? So once a clinical decision has been made, and that's the part I want to touch on just for a moment, it is a decision. It's something that does need to be discussed, needs to be thought about, and it does not need to be taken lightly because, again, you are working toward this throughout your time, throughout the treatment of this individual. You're pursuing discharge. Having a discussion with the therapist involved, having a discussion with the med provider, if there's one involved, having a discussion with the supervisors involved with this member, and ensuring that, yes, as a team, the member is ready for discharge. Then it comes time for the care coordinator, therapist, or nurse, or whomever to do that, to complete the discharge summary. And so some of the things that we would be looking for on a discharge summary, why is the member being discharged? What was the member successful in? Or, in some cases, unfortunately, what was the member not successful in? Making sure that information is clearly identified. You want to clearly identify the progress made, where they started and where they ended in the service. You want to be able to identify, the fruits of the treatment, what has really been provided to the member. The other item that we sometimes get questions around is well, what do we do if we've been unable to contact a member? Maybe we met with the member in January and it's now April and we haven't seen them. They're not answering their phone. They're not coming in for the med appointment. There's no information in the ADT feed. They're not going into the hospital. We don't know where they are. We haven't been able to contact them. So the reviewers for the THL engagement evaluation, we've discussed that previously, and have used pretty much a 3-month or a 90-day kind of guideline around, at that point, if you've been attempting to engage a member and you've varied those attempts, maybe you've tried a phone call, maybe it's been a letter, reaching out to the primary care doctor, reaching out to the pharmacy, emergency contact, in some cases doing a drive-by visit and seeing if they're there at home. And remember, again, all of those have been unsuccessful. Going back to the beginning of our discussion and looking at the limitation of resources, there are a lot of members out there that need this service and can benefit from this service. And it's not a final approach to discharge a member if they've fallen out of service. They can be re-engaged. But again, using a rough 90-day guideline saying, we've made several attempts, we've pursued it, we can show evidence of that, it's documented, we're going to discharge this member and see if we cannot engage another member and someone that also needs this service. So that is something to be mindful of, and making sure that you're documenting appropriately.
And the way you will document so that we can, at the MCO level, will know that you have discharged a member is through the steps listed here on your screen. So each MCO has their own portal for THL where you will discharge the member through that portal. It's been in place for quite some time, but we are always open to any refresher training or re-education for your staff on how to discharge. Note there is always a lag in that data feeding over to the care coordination tool and into the attribution files. So please be mindful of that if you discharge someone, it's not going to show up immediately. There is typically a 2-week or so lag for most of the MCOs. It could be a little shorter or a little longer, but you can contact your individual MCOs and get those specific guidelines if needed, or if you need any more information on the specific portals.
So another question that we sometimes get is, the importance of notifying the MCO. And, you mentioned just briefly about so that accurate reporting occurs. Thing to be mindful of is with the outcome reports and part of the financial side of this program, members that are discharged are removed from the performance panel once they've been discharged. They're not attributed or enrolled for at least 9 months. They can be pulled out of that attribution panel, that performance panel, once they are discharged. Also is opted out. That's the other item that members opted out. They're removed from that as well. That is a very important feature to remember when you're working with these individuals and being mindful of and making sure that that information is communicated back to the MCOs in a timely manner so that accurate reporting and discussions and planning and interventions, not only at the member level, but at the provider and MCO and state level, we need that accurate data so that we can accurately measure the impact of this program. And so please be mindful of that. Please be sure to communicate that to us. If there's any questions about that, again, through the chat function, you can drop it through there, or you can reach out to your specific MCO. The next item that we're going to look at is just a very brief case study, and just this is to help facilitate discussion, facilitate questions. And so you'll see on your screen here just a brief case study. A 39-year-old unmarried male named John that was receiving services at a CMHC, had a history of schizophrenia, had diabetes. He was receiving treatment from his PCP, but again, at this point they had identified that there was some need. And so he was referred to Tennessee HealthLink by his psychiatric nurse practitioner, partially for coordination of care, but partially for suitable housing. had 19 ED visits in the past year, had difficulty remembering to take his medication. He had unstable housing. He was frequently homeless. So this is kind of the approach that was taken. So once the team met with John, they identified not only the few things that the psychiatric nurse practitioner had identified, but that he was also having difficulty with his finances. He was frequently running out of money before the end of the month. And so the next page, this is just a snapshot of a care plan, just for illustrative purposes. And so one of the problems is limited knowledge of managing his diabetes. Talks about improving health maintenance with diabetic medications and treatment, taking all the medications as prescribed, utilizing community resources to assist with his needs, and making and keeping all of his appointments. And so part of that, the THL team working with John to coordinate care, so reaching out to the primary care provider, but then also, again, with the housing, making sure that they can get him into suitable housing, reaching out to the community housing organizations. Through their analysis and their assessment, they learned that a lot of the ED visits were related to his diabetes, not necessarily to his behavioral health issues, but on the medical side. So one of the goals that they had, in addition to what we mentioned just briefly, was reducing the ED visits to none in the past 3 months. And if you're going from an average of 19 per year to 0 for the quarter, that's a pretty significant decrease. So the interventions that they used is partially by organizing his medications, making sure that he understood those, and getting him in with the appropriate provider to provide that education, setting up a reminder system so that he would take his medication. They actually working with him to get some understanding of nutrition and working with the dietitian to improve his diet. They also worked to set up a way to manage his money with a payer so that he could afford the health care that he needed and the foods that he needed and the housing that he needed. And then, of course, a big item was to help him find that stable housing. So once those things had been achieved, John was stable. He had met those goals that had been outlined for him. The team met, they discussed, they reviewed his case, and they decided that he was ready for discharge from THL. That did not mean that he quit receiving services from his CMHC. It did not mean that he quit receiving services from his primary care doctor. It merely meant that he had reached a point where he was able to manage his functioning, his current level of care. He was able to manage that effectively on his own. And that's a good thing for a member to be able to identify that, yes, they can be successful, and yes, they can do it. So they went through, they discharged him, they documented all of that, they made sure to work with him and that all of his needs were met during that discharge process and that he continued on. And again, the important thing is, and this is what we're going to discuss next, is if John begins having difficulty and he has problems, he loses housing, or maybe his diabetes, he begins having additional issues, something of that nature, they can look at getting him back into Tennessee HealthLink, getting him back in with that provider and re-enrolling him. So the things that would be required, the licensed clinician recommendation for service, we need to make sure that that is occurring. We need to make sure that the informed consent, this is what THL can do, this is what we can assist with, this is what we cannot assist with. Making sure that discussion is happening and that consent is signed. And then evaluating John and seeing what is his current needs, not going off of what may have been happening 6, 8, 10, 12 months ago, but where is he at currently? Thing to be mindful of is, yes, attestation is required. So you would need to go in, attest to them through the various ways depending on the MCO. You need to make sure that all of the documentation around that is there. And then you also need to have that discussion that just because he needed some more assistance doesn't necessarily mean that he is going to need it forever. Just because he did not succeed one time doesn't mean he cannot be successful ever. And so you want to make sure that is being mindful. And again, you know, if you go back to the previous slide, slide 13, which you can reference on your own or through the level of care guidelines in those domains, making sure that you're not only just assessing the housing and the medical needs, but seeing what it is that's driving that relapse. What is it that's causing that lower level of functioning? Because there may be something that recently came up. It may have been a loss of a loved one. It may be something entirely different that's impacting him currently. Making sure that that assessment is updated, and you really evaluate what the member needs, what they want from the service, what they're pursuing, what the service can provide, and at what point is success going to be identified with that member. So that is just a brief overview. We have about 20 minutes left, so we have plenty of time for questions, and we know that we've had a lot of questions come up around this subject with providers, and so I'd love to hear from some of you now around any questions that you may have.
Kyle, we've got one question. So many of our members have so many issues that they need to work on that it may take years to meet all of their goals, and new things come up along the way. Can you speak to that?
So again, one of the facets, one of the foundations of this program is that functional assessment and that medical necessity piece. And yes, there are some members that are out there that are receiving a service that are, severely and persistently mentally ill, and they are working toward and making progress on goals, but there are several goals. There are many things that are identified, and sometimes it's best to narrow that focus, work on 2 or 3, 4 things, and prioritize so that the member is not being overwhelmed. One of the changes to the engagement evaluation recently was the addition of the item regarding the 6-month functional assessment and 6-month update to the care plan. Part of the reason for that is making sure that the providers are identifying where the member is currently. And so, yes, there may be cases where the member needs a service longer than what would be considered average, perhaps. And that's not necessarily a bad thing as long as that assessment is happening, that documentation is supporting it, and you are actively working toward those goals. Again, there is the item around monitoring, and if the members, you've attempted to discharge and they've been unsuccessful. But for a member that has several goals and, maybe housing, it takes a year, 18 months to get them in stable housing sometimes. That's where the documentation and making sure that you're supporting that need really comes into play. Hope that helps.
Got another question.
Good.
How do we get clients who are attributed to us off of our list?
So when a member is attributed, there's only a couple of ways that a member can actually come off of that attribution list, and that is essentially if they lose eligibility for the service through one of several ways. Again, I mentioned incarceration. I mentioned, if they pass away, of course. They're not eligible for THL if they've passed away, okay? Let's just be clear about that. And then if the member opts out is another method that, they would lose eligibility, of course, if they decline the service, they no longer want it. If a member is attributed to you currently, there's not a way that you can just go in and remove them from your attribution without engaging with the member in some way. And the reason why that is because you have no way of saying that they do not need the service without engaging with that member. And so currently there is not a process for them coming off your attribution unless they lose eligibility or you engage with the member and they tell you, I do not want it, and you can opt them out.
We've got another question. Homeless members can be a challenge to coordinate with. It seems like just as soon as we discharge them, they are back for care. Can we relax the timeline for some of them?
So that's really where, you know, that clinical discussion and having a discussion with the treatment team and showing that documentation, showing that support for, well, maybe you wait an extra 2 weeks or an extra month. But then also the thing that I would be asking is if you see a member and they've done that once, they've done it twice, maybe even 3 times, which is not unheard of. We probably have all seen instances of that occurring. Making sure that you're evaluating the interventions, the things that you have in place, and is it meeting the member's needs? Is it really helping them where they're at currently, or does the treatment plan need to be revamped entirely and a different approach taken? So again, there's a lot of things that really gets down into the clinical decision-making piece. And having that discussion and then supporting it with the appropriate documentation. And it really is that would probably be one that a case-by-case situation, having the discussion with the specific MCO, identifying those members that are hard to engage, that are, you know, coming in and out through the revolving door.
Got another question. What are some pointers that we can use for working with children and adolescents?
Okay. So, children and adolescents. So this is one that is a little bit difficult because in working with this population, it's a little bit different. And there's specific level of care guidelines. So there's specific criteria that come into play when you start working with children and adolescents. And ensuring that, again, is it that the member, the child, and their support system, you know, is it that they really need the service? Or, you know, at some point the question becomes, is it the parent that needs the service? And ensuring that you have the appropriate primary patient identified in the service. Now, again, children and adolescents are eligible for this service and can receive it, but sometimes it's important to remember that if the actual patient is the parent, then the actual patient is the parent. And so working with the children, you may actually end up discharging the child or the adolescent and enrolling the parent and working with them on their specific needs, their specific issues, and therefore addressing several of the surrounding items as well. Again, looking at the specific level of care guidelines for children and adolescents, which are on all 3 of the MCO's websites, and if you have a specific example, reaching out to the MCO and having that discussion. I know they're more than willing to have that discussion with you and walk through any specific case-by-case issues. So.
Yeah, and I was going to say, just, you know, my experience working with kids and definitely adolescents, you do have to be very individual in your approach, and I'm sure you guys know that. So it may be looking at integrated care coordination with that population. You might have to engage the team a little bit more to figure out what's the best way to get that child engaged in the service. And it might be just reframing how you're presenting information, and I can see that being easier if it was a teenager, but maybe a younger child, maybe just looking, talking to other people on the care team to figure out how to engage. You know, maybe you would have a call with a pediatric doctor or the family nurse practitioner to see how you can bring in some of those physical health components to that conversation. But I think with that particular population, you do just have to get really specific and individualized when it comes to working with them on integrated care. Jennifer, were you going to?
Yeah, I think also some things that we've heard out in the field working with some of you is sometimes it's hard to get the parents to buy into the care plan or abide by it. And I know, you know, I have an 8-year-old and a 4-year-old, and sometimes I have to put things in a certain context so that they understand why something is important and why I want them to do something. So I think if you're working with the children, sometimes, you know, if they're at risk for diabetes, you know, educating them in a way that they understand about the foods that they eat and, you know, getting appropriate exercise, drinking water instead of soda, things that if the parent is not fully engaged, you may be able to put things in a certain context, a certain way that would, you know, the children would understand. And I know that that can be a tricky meeting to have if the mom or dad is not fully engaged, or maybe if the child's in, you know, with a grandparent, they may not always fully buy into the care plan, but sometimes you may be able to just, you know, include the child in that discussion and possibly, you know, they can be a little more hands-on with their own care, especially adolescents.
So another thing to be mindful of is, you know, that treatment plan. And what is it that the goal with that child and adolescent, what is what's the target, what's the end state that they're working toward, and making sure that that is an appropriate target for that patient. And again, so that's the important thing to be mindful of is when you're working with children and adolescents or with families, is making sure that that documentation supports the identified patient.
Kyle, would you say that the care plan for a child and adolescent would be more simplistic than it would an adult, so that way it's easier for them to understand, easier for the family to understand? Would you say that you would have to tailor that care plan?
Well, and that's the important thing about it being a person-centered care plan. So if you're working with an 8-year-old or a 9-year-old, then it stands to reason that that care plan is going to be different than if you're working with a 34 or 35-year-old. The measurability of it, the specificity of it, you know, and the approaches like Jennifer was mentioning, those are going to be different for a child or an adolescent than for a middle-aged adult.
We do have a few more questions, not off the hook yet, sorry. If the client is no longer participating or we cannot get a hold of the client, how long do we have to attempt to reach them?
So I mentioned this earlier in that the 3 MCOs, the group of the THL engagement evaluators, the ones that go on site, we had discussed this around a year ago or so, and we'll touch base on this again, but we really kind of use a 90-day time frame of attempts to engage, and so that's for the quarter. You know, if you've been unable to engage a member for 3 months, and you've tried, again, there's documented attempts to engage, and that's one of the questions that we look for on the engagement evaluation. And it's just been unsuccessful. The member is not engaging in the service. Then at that time, it's appropriate to have the discussion, should we discharge them or should we not? Sometimes that answer will be, no, we shouldn't discharge them. They're still going into the hospital. They're still going to the ER. You know, there's some opportunities there that maybe we haven't pursued to engage the member. Sometimes the answer is yes, because, you know what, we just had this member that came in yesterday that really needs this service and is here now and engaged, and we think we could do, you know, we could help that member and they're working with you, then yeah, perhaps the answer is yes, it's time to discharge that member. And if they come back in, or if they go back into the ER, the inpatient, CSU, whatever it may be, picking that member back up, trying to re-engage them, and having that sometimes difficult conversation at the beginning of, you know, you were receiving this service and we had some difficulty engaging with you. Do you want it? Is this something that you're willing to work with us on? There's a mindset out there that of a passive opt-out, you know, essentially where you engage the member and then they disappear, and they're passively telling you, I don't want this service. I don't want you bothering me. I don't want to work with you. I don't want any of this. Sometimes you have to have that discussion with them about, okay, if you don't want the service, we need to have that discussion. We need to identify that. If you do want the service, then we need to set some realistic expectations on engagement and making sure that the member understands from the get-go there's an expectation that they will be involved in that service.
Got 2 more questions. What do you consider acceptable verified efforts to engage a member who is less adherent to THL services before discharging them? For example, showing 1 phone attempt per month for 3 months and then a final letter, or would more effort be needed?
I'll kind of take that one. You know, I would say that there would be a variety of attempts. I mean, and I know that gets difficult, but I would say, you know, there's a document of a phone call. There's documentation of a visit. I know sometimes when I wanted to just do a quick drop-by, I had to make sure that I was already in the area seeing another client. So you might just drop by that person's house. It might be a letter. It might be touching base with the collateral. I would definitely say the file needs to show that there were different ways to try and engage the member more than just a phone call.
And I'll agree. The question on the THL engagement evaluation tool identifies varied attempts. And so, you know, whether that is outreaching to the primary care doctor, outreaching to the pharmacy, outreaching to the emergency contact, outreaching to the school. One of the things that we frequently see is we see a child and they haven't been engaged, they haven't been seen, but we don't see a contact with the school during the school year or something of that nature. So, again, that varied attempts is something to be mindful of, making sure that if the phone number didn't work 1 month and it doesn't work the second month, maybe let's try something a little bit different and vary that approach.
And I would just make sure, you know, you document clearly the efforts. Like if you did a home visit, this is the address, and if you made a phone call, this was the result. If you sent a letter, this was the address that you sent it to. And then sometimes, you know, you might have to go back in, hey, I reached out, didn't get anything. But I would say making sure that the documentation also supports exactly what happened when you tried to make that attempt also.
And I think I want to give credit where credit is due, definitely, in that we have seen that documentation improve. I know, you know, in charts that I've seen that documentation improve. I've seen those attempts increase. But again, I think there are some opportunities, and that's where that team approach and having that discussion, sometimes even peer-to-peer, where you're working with a couple of case managers that sit down for 30 minutes once a week or something, review cases and saying, hey, you know, this kind of sticks out. Have you tried contacting this, or have you tried this approach, done this? And that's not only for contact attempts, but that's also for interventions when we're dealing with difficult cases. Having that kind of peer-to-peer supervision is beneficial. So, yes, another question.
I think this is the final one. It seems like members get lost when there's a transfer to another provider, especially for youth transitioning to adult services. Do you have any recommendations to prevent them being lost in the process and have to be discharged?
Well, I think that is something that perhaps we need to look at various MCOs and have a discussion on some specific examples and specific cases. You know, one of the things that I would be looking at is, you know, from a care coordination perspective, making sure that that coordination is happening all the way through. And, you know, again, this is the attestation process is switched to month basis. So, you know, having that warm handoff and ensuring that that transition is occurring is something that could be addressed, and perhaps it's something where you sit down with that other provider and identify a specific process. So if you know that your child and adolescents primarily, and you refer to this THL whenever they become an adult or something of that nature, and that's all purely hypothetical, but having that discussion with that provider or those providers, if there's multiple ones, to identify what is the best process for that. Where can we improve? We've seen a lot of that discussion happen with inpatient units and CSUs. Perhaps now then the next step is to have that discussion on the outpatient side. Do we have any more questions? I know we have 2 minutes left. All right, so one thing I do want to be mindful of is, again, this is just a very brief overview. I mean, we could talk about discharge for quite some time. I know there's probably a lot more questions than what have been asked. All of you as providers have a wealth of resources available to you. You have your various MCO contacts, whether that's the engagement evaluation, the people that come on site and conduct those, your contacts on your contracting side or operations side, you know, for United, Jennifer or Amanda, or in Blue Care and AmeriGroup, they have those various contacts. All of you have someone that you can reach out to with these questions. Do not hesitate. We are here to help in any way that we can, and I think I'll freely speak for all 3 MCOs as well as TennCare regarding we will gladly answer any questions around this that you have, and we will work together to try to address any of those that may come up. So please do not hesitate to reach out. And if you have any questions about anything that I've spoke about today, again, don't hesitate to outreach to me directly. I think there's some resources, and most of you have my contact information. If not, then please contact your contact at United, and they'll get in touch with me.
All right. Well, thank you, Kyle and Jennifer. Thanks, Navigant, for being here and hosting the webinar. It is exactly 12 noon. You guys have a good day.